time off from his schedule to say, okay, I'm going to come, and here I am, I'm going to present. And it's not just about the message of medical, it's our Christian duty to keep ourselves healthy, to eat well and live well, right? So today we are here, and when we announce this program, most persons believe it's just for men. However, I said to persons, if you're a sister to a brother, a niece to an uncle, a daughter to a father, a wife to a husband, don't you need to know? Don't you need to know? Yes, because we know men can be stubborn. So there you go, I'll leave it there. So I won't get into anything else. But I'm happy to welcome you here on behalf of the men's ministry. And hopefully, what is said here too will be benefit for all of us. And we will be able to address this issue in a better way. Now I'm going to ask Sister Sydney to come, introduce our speaker, and tell us more about this special gentleman.
Good evening, everyone. So I have been given the simple task of introducing this afternoon's presenter, and it gives me great joy to do so. I could tell you a whole lot about this young man. I could even tell you things about him from before he was born. But they gave me a script, and so I'm going to stick to the script. Dr. Hoylett is a medical oncologist, hematologist, and healthcare quality leader at Jamaica Hospital Medical Center, part of the Medicis Health Network. In clinical affiliation with Memorial Sloan Kettering Cancer Center. He is dedicated to providing compassionate, comprehensive, and patient-centered cancer care to diverse communities of Queens and the greater New York area. Dr. Hoylett earned his medical degree from Loma Linda University School of Medicine in California. He then completed his residency in internal medicine and fellowship training in hematology and oncology at the Zucker School of Medicine at Hofstra Northwell Health. As a hematologist and medical oncologist, Dr. Hoylett treats patients with a broad range of solid tumors and hematologic conditions. His clinical interests include prostate, kidney, colorectal, and lung cancers, as well as blood disorders such as anemia, leukemia, and lymphoma. He's committed to individualized care that addresses the medical complexity of illness alongside the emotional, practical, and personal needs of each patient and family. In his quality role, Dr. Hoylett works to strengthen systems of care, promote patient safety, improve the patient experience, and support the consistent delivery of high-quality oncology services. His professional interests include cancer prevention, early detection, health education, healthcare innovation, and advancing equitable access to timely, high-quality cancer care. Dr. Hoylett's path into medicine was profoundly shaped by witnessing the effects of cancer on individuals and families in his community. Those early experiences inspired a lasting interest in cancer biology, and a commitment to helping patients navigate difficult diagnoses with knowledge, dignity, and hope. They also deepened his awareness of disparities in healthcare access and continue to guide his efforts to build trust and ensure that patients receive the support they need throughout their treatment journey. Brothers and sisters, I crave your undivided attention for the presenter, my son, my firstborn, Dr. Aldain Kadim Hoylett. Please make him welcome.
All right, happy Sabbath, everyone. It's still Sabbath. How are you guys doing? All right, so I think initially we were going to talk about just prostate. Are we able to get the slides on the back screen? Perfect. But I think I'm going to talk a little bit about colon cancer as well as prostate cancer because both of these affect men significantly. Prostate cancer is is the most common cancer that we see among men. And as of 2025, colon cancer is number 3. So who is counting on you is one of the most important reasons why we're having this conversation today, because your health is a part of your legacy. And your legacy involves your family, your church family, and your friends. And so paying attention to your health and being around for them is very important. And most importantly, we have to remember that your body is the temple of God. In 1 Corinthians 6, verse 19, it says, "Do you not know that your bodies are the temples of the Holy Spirit?" So the basis of this whole entire presentation is that we are preserving the temple that God gave to us. So 3 main things to remember. I wish I could see that screen, so I'm going to go to the side. The first thing I want to emphasize in this talk is that you should know your risk, and that's your family history and your background. The second thing is that you should pay attention to the changes that occur within your own body. And I'll say this a lot of the times, you know your body more than anyone else does. And so if you go to your doctor and you're like, I think something is off, and you're being ignored, I think it's time for you to get a second opinion, because if you feel like something is off, it is likely that something is off because no one knows you better than you do. You are not a textbook that we read in school. Sure, some things might align, but there are things that are happening within you that only you can sense, and you have to go to someone who will listen to you, and you have to advocate for yourself to say, I know something is wrong, I need someone to pay attention to my concerns. And then we'll also focus on what you can do to prevent cancer, particularly prostate and colon cancer, and that is to get screened. So the 2 cancers here with the same message: early detection and early action saves lives. These pictures are just showing you where those organs are located, and we'll look at them closer when we talk about each. One of the first things is that you need to know your family history. This is very, very important. I know a lot of people, a lot of us are immigrants, and you don't know exactly what happened with your grandpa or your uncle, but it's important to try finding out. A lot of times we don't talk about it because they say, oh, he died because he was old or he was ill. And some of the times they have illnesses that they know about, but they don't want to talk about, that affects you and your children in the future. And they might say, oh, he had cancer, but it's important to find out what type of cancer that they had, because that determines your risk for having that cancer as well. And also something that we overlook is that you need to pay attention to what age these cancers come about. So say for colon cancer, which we'll talk about, the age that your family member was diagnosed might determine how soon you should get screened, okay? And this is for the men especially. We tend to think that when something goes wrong, it is something that we did. And sometimes, yes, because some of the risk factors we do bring on ourselves, but what are the circumstances that led us to developing those risk factors to begin with? A lot of times it's just not your fault. And even if one could say that you played a role in it, focusing on the fact that you had something to do with it doesn't improve the outcome and actually makes it worse. What you should focus on is taking action and controlling the things that you are able to control. So let's start with the prostate. Looking at this image, the lighter pink organ at the top is the bladder. That's where you store your urine. And then the smaller, darker pink organ below that is the prostate. So as you can see, the prostate is directly below the bladder, and that tube that takes the urine out from the bladder runs through the prostate. And so that is why a lot of the times that someone has prostate cancer, it prevents with issues with peeing. So you're not able to pass urine freely, or you think you're passing it and it gets stuck and you have to keep going to the bathroom. And for some people, sometimes they see blood in the urine. So this is why it's because of the location. For some others, it can also cause constipation, meaning you can't defecate or poop because it's pressing on that area also. So those are signs that could potentially indicate that something is wrong. So it's very important to pay attention to what is going on with you. Some quick facts about prostate cancer and statistics. It was the second most common in men worldwide. It's slowly creeping up to being number one. Lung cancer is giving it a fight. Estimated 313,000 new cases in 2025 alone, and 35,800 deaths, and that's just within the US. We're not talking about the Caribbean or Africa or anywhere else. The good thing with prostate cancer is the overall survival is good. And that's because we are doing more screenings and catching it earlier. So 98% overall survival, and when we say overall survival, we're focusing on 5 years from diagnosis. However, if it's diagnosed later on in the stages, like stage 4, then that survival drops to about 40%. So this tells us why it's super important to pay attention and talk to your doctor about what's going on. If you suspect something is wrong and you're not peeing well, seek help. All right, so Black men face a higher prostate cancer burden. And we know this, it's not unique to the US. We find that in countries like Jamaica, Jamaica has one of the highest rates of prostate cancer diagnoses and deaths, and that expands to the rest of the Caribbean. So speaking to most of us here, we automatically have a higher risk of developing prostate cancer. Now, this number 45 is something that is questionable in the realm of medicine, but it's an acceptable standard that at age 45, you should start discussing with your doctor whether or not you need to get screening for prostate cancer. Now, this is not saying you should get screened at 45. It means at 45, you should say, hey, what are my risks of getting prostate cancer? They'll ask you about your family history and all that other information, and they'll determine the risk versus benefits with you of starting that screening now or waiting until later. And you might say, why do we have to have a discussion? Why not get it? The reason is that sometimes we do these screenings and we get a number that's slightly higher than normal, and it induces panic for nothing, or we go and we discover something that didn't need to get treated or didn't need to get worked up. And so we have to weigh the risks of benefits of going through a whole workup process and the anxiety and the time off from work and the financial constraints that come with that. So that's why we say have the conversation as opposed to just going straight for screening. Risk factors, let's go deeper into those. So one of the main things that we know affects one's risk of having prostate cancer is the genetics, and that's where the family history comes in. So if you have a first-degree relative with prostate cancer, you are twice as likely to develop that. So if your father has prostate cancer, your risk is doubled, and then it becomes your uncle, and then it goes out to your grandpa and so forth. The closer you are to that person, the higher your risk. Black men have a 2 times higher mortality. So not only do we have a higher rate of diagnosis, but you have a higher chance of dying from this. The reason could be the fact that we end up having higher or more aggressive forms of the cancer. But the other issue is that most Black men do not seek care until something is absolutely wrong. And by that time, they have had this cancer for a while, and now it's spread stage 4. And as we looked at the stats before, the chances of surviving 5 years has dropped from 98% to 38% at that point. Germline mutations, I wrote those there because these are the common ones that you might see. So you'll always hear them talking about BRCA1 and 2 for breast cancer for women. It's not only women that can be affected by this mutation. So if you have a sister or an aunt or your mom had a BRCA1 mutation, as a male, you're not free from the burden of that mutation. You can develop things like prostate cancer. So it's important to pay attention when your family is talking about these things. You're like, oh, it's breast cancer. That doesn't apply to me. I don't have to pay attention. You do need to pay attention. Lynch syndrome is something that affects prostate cancer and colon cancer as well. These are names that you will hear thrown around if you spend enough time going to the doctor and getting things worked up, or you have family members who are going through certain diagnosis. So I want you to pay attention if you ever hear these words or terms. Ask a bit more about how they relate to you and your risk. Like, does your family have this? Is this confirmed? Or are they saying they don't have it and it's something you don't have to worry about? And then the most important risk factor is the ones that you can control, and those we call modifiable risk factors. So your diet, weight, and smoking and alcohol use, those are important. You might say the people in here don't smoke, don't drink, but if this is something that you did in the past, it could still have an effect on your chance of developing cancer. And then this message is not for us, just not for us in here, but for the people you know, your friends and your relatives who aren't Adventists, who don't come to church, the ones who drink, the ones who smoke. This is something that you could use to help them to get to the point of quitting or realizing that it's important that they stop doing these things. Early prostate cancer can be silent, and that's something that we hear a lot. People say, why do I need to go to the doctor? I feel well, nothing is wrong with me. A lot of the times with prostate cancer and with any cancer for that matter, you don't know that it's there until it's too late. And in prostate cancer, colon cancer, there's something we could do to detect it early, so that's why we focus on screening so much. So, changes, we talked about these. If you have issues with starting or stopping your urine, you should get that checked out. If you're going too often, you should get that checked out. If you see blood or in your urine or semen, that's something to get urology to evaluate you for. And if you have persistent pain. And the pain does not only have to be in the pelvic area. One of the first places that prostate cancer goes to is the spine. So if you have back pain that it's kind of weird and it's getting worse and it's not just muscle pain, you might want to figure out what's going on with that. I mean, it could be something else, so you don't have to bank on the fact that this is prostate cancer, but that by itself should prompt you to get checked out. If you have back pain and you have issues with urinating, then putting those two together increases your risk that you do have something going on with the prostate. I don't know how many of you have heard about PSA, but this is the test that we do to screen for prostate cancer. It is a blood test. I know a lot of men are scared of having this conversation because the first thing they think is that their doctor is going to recommend them for a rectal exam. Maybe back in the day, that's what they did, but now that we have advanced, we have this simple blood test. You go for your regular blood, they get this number, they look at it, and they determine whether or not they need to keep checking it, or we could wait a while before we talk about it again. It is not a diagnosis. So a high PSA does not mean you have prostate cancer. Other things can cause it. Other things can cause the urination issues that you're having. One of the most common things that we see in men affecting the prostate is something we call BPH, where your prostate gets big, as if it would when you have cancer, but isn't something that's evenly getting big. So in prostate cancer, you have one part that gets big, the rest stays normal. With this BPH that causes similar symptoms, the entire prostate gets big altogether, but the symptoms are the same. So that's why all of this is not a diagnosis by itself. It just means that you need to get checked out. So when you have a high PSA, your doctor will talk to you more about what the next steps are, because it's not a one size fit all. You might say, oh, my friend had it and he was okay, I don't need to do anything. That might not be the case for you. The opposite might be true, where your friend had a PSA that was high but lower than yours and it was cancer. It doesn't mean that yours is cancer either. So it's all about conversations and not trying to diagnose yourself. So I said most of this already. One number, single value is not the whole picture. We usually trend it to see how it's going. So if we check it, the usual number is 0 to 4. 4 is where we usually become concerned. But say you have a PSA that was 3.9, the doctor might say, let's check this again in 6 months. If it's going up, then we become concerned. If it's stable, we're like, okay, let's check it again. We don't need to do a biopsy and so forth. And then it all has to do with what are your risks, what's your age. The older you are, the higher the chances that this could be cancer. If you have family members that had prostate cancer, then the chances are higher. So it's the full picture. It's not a one size fit all, like I've said before. And now to talk about screening. Screening is not the same as evaluation. What do I mean by that? So for most of this conversation, we've been talking about getting evaluated if you have symptoms. That's something you have to do right away. The screening itself is for the person sitting here today who meets the criteria. They have a close relative that had prostate cancer, and you're Black, and you're 55. You are the person who needs to go get screened. It's not something you have to do tomorrow. When you go see your doctor for your next checkup, you say, hey, I think I want to talk to you about my risk for prostate cancer and whether or not I should have that blood test to see if I should have more testing done for potential early diagnosis. Evaluation is, I don't feel real well right now, I have issues with peeing. You or someone who I would recommend calling your doctor next week and say, something is wrong with me, can we have that checked out? So how do we truly diagnose? Because we talked about the PSA and I said that that's not the diagnosis. So what usually happens is that if we see a trend in the PSA that is concerned, then your doctor will send you for an MRI. So still nothing invasive, you're just going through a machine. Some people do hate the MRI because they feel like it's a tight space, but still no one is poking inside your body at this point. They're checking the MRI to see if there's anything on the prostate that doesn't look normal. If we see that, then we send you to a urologist or a specialized surgeon who does a biopsy. And that's when they go in with a needle and they take samples from all around the prostate. Usually it's 12 small samples, and they send that to another doctor who's the pathologist, and they look at it under a microscope and they decide whether or not you have cancer cells present. If there are cancer cells there, then they will determine who you see next. It could be me, or it could be the same surgeon that did the procedure. And when I say me, I'm a medical oncologist, so I'm usually the one giving hormone therapies and chemotherapy and immune therapy. If it's early prostate cancer, then you wouldn't need to see someone like me. The surgeon who did the biopsy would talk to you about getting localized treatment, which we'll talk about. It involves surgery versus radiation. So this is also important because the earlier you get detected, the less strenuous and toxic the treatment you receive is. So the quicker you're back to doing the things that you were doing prior to this diagnosis. I don't know if you guys could see this slide. So we have different situations or different stagings for prostate cancer. If someone is low risk, meaning we do find cancer cells, but when we put the whole picture of the PSA and what the cells look like under the microscope, we're like, you probably would have lived with this cancer until death, and it would have caused no issues for you. People like those, we don't recommend treatment for. We just keep watching you actively by doing PSAs and more imaging to see if the cancer is evolving. And that's because we're weighing the risk versus benefits of treatment. Every treatment that we give has a side effect. So if we could spare you that side effect and you still keep living your life and you don't have a higher risk of dying, then there's no point in treating you. For others who have prostate cancer that's just confined to the prostate, that's where we talk about surgery versus radiation. And if it's a little bit more advanced, meaning that it's affecting the areas around the prostate, then we have to talk about doing things like hormone therapies. The moment it spreads to a distant part of the body, say the liver or the bones, then we have to talk about more intense treatment. Thank you. And that intense treatment will be a combination of injections or pills, and some people do need chemotherapy. Again, the earlier you get screened, the earlier you get caught, then the less likely you are to need advanced treatment. It's important to distinguish between early versus advanced in the sense of treatment, and this goes for prostate cancer, colon cancer, breast cancer, any cancer. When you have stage 1 to 3 disease, we're usually able to cure you, meaning we have treatments that will get rid of the cancer and we could stop the treatment and keep watching you over a few years. If you have cancer that has spread to other organs like the liver and the bones, it's highly unlikely that we are able to cure you, meaning you would be on treatment forever. Even if you're 55 at the time of diagnosis, you're gonna be on those treatments until they stop working and we try something else, because the moment we stop those treatments, the cancer is going to get worse. So that's why we emphasize screening and early detection, because screening and early detection equals lower stage at diagnosis, which means longer life and less treatment, and you could go back to normal life. The goal is to minimally affect your life as much as possible. So we talked about the prostate. Let's quickly talk about colon. I won't spend as much time on it, but it's also something that's important. The colon is what we call the large intestine. So you have the small intestine and the large intestine. On this diagram, it's a darker pink portion that's making that kind of box around everything else. That's the colon, and that's where your food goes when it's ready to go out the body, and it travels all the way around and then it comes out. It usually starts as a polyp. So looking at this diagram, the normal lining is just the pink line with nothing on it. If someone has a normal colon on the colonoscopy, that's what it will look like, just normal, flat, nothing. If a polyp is growing, then you have something pushing out of that normal lining, and at that stage, it's very easy to get rid of. They just cut it out when they go in, and that's it. However, if we don't detect it early, then it starts to do things like this, where at first you had a small polyp, then it becomes a big polyp. Then within that polyp, those cells start turning bad, like that yellow you see within. And then the yellow part starts to grow until it comes out of the colon, the wall, the lining, and starts going elsewhere in the body. So you can see that if someone got screened when they just had a small polyp, the treatment would be way easier than if you got to the last stage that we see at the end. This can also be silent. So we see a lot of these cases, and we're seeing more and more where someone comes in and they had no symptoms or very little symptom in terms of changes in their stool, and then we end up doing a scan and they have colon cancer everywhere. So it's important to know your risks so you could determine when to get checked. Things that should prompt you to go see a doctor: if you have blood in your stool, that is not normal. Male, female, there should be no blood in your stool. If you see that, I would tell you to go to the emergency room and get that checked out. The reason is we don't know what's causing that bleed. It could be cancer, it could be a bad blood vessel, we don't know. And we don't know how that bleed will progress. For some people, they keep bleeding slowly over time and their body adapts. For others, that bleed gets worse very quickly, and then you're losing all the blood that you have in your body and you can't make it back fast enough, and you might pass out and you might not make it. So blood in the stool is very important. It is a warning sign of colon cancer, but that's not the only thing that it signifies. but whatever it signifies, it is serious. Bowel changes. So if you realize that you know how your body acts. You know when you go to the bathroom what it looks like, and it's important to look. Because if you don't look, you don't know what your normal is. I know a lot of us don't want to look because it's gross, but it's a part of you that you need to know so that when it changes, you could track those changes and say, something is not right. Let me go talk to my doctor about this. If it's all of a sudden you're having constipation and you didn't do anything different, you try the over-the-counter medications and this persists for months, then you should go get help and stop trying to treat yourself. If you are having any of these, like the bowel changes, and then you all of a sudden are losing weight and you're not trying to lose weight, that could signify not only colon cancer, but any cancer in general. Weight loss and quick weight loss that is not intentional is a warning sign. There are other things that could cause weight loss, like thyroid issues or diabetes, but the most concerning thing is cancer. Yes? All right. So risk factors for colon cancer, age 45 years or older, that is very, very, very questionable, but that's where we are right now. It used to be 50, now we're down to 45. If you have polyps, so if you do a colonoscopy and you have polyps, that places you at a higher risk of having cancer in the future. And so that's why instead of telling you to come back in 10 years, they might say come back in 3 years. They don't want more money or they don't want anything extra. They're looking out for you. Because I've heard that they're like, oh, the doctor only wants me to come back so he can make more money. Highly unlikely. If you suffer from things like ulcerative colitis and Crohn's disease, I won't explain what those are, but if you have those, you would know what they are. You are at a higher risk of developing colon cancer. If you have a close relative who was diagnosed before the age of 50. So this is where it goes back to my history and finding out not only the cancer, but the age. Because if you have someone diagnosed at the age of 50, say your sister or your dad, then you do not wait till you're 45 to get screened. You're gonna get screened 10 years before they got the diagnosis or at age 40, whichever is earlier. So it's very important to know your family history. And if you have certain mutations, we talked about the Lynch syndrome. There's another one that's called FAP. I put these out there in case you hear someone in your family say it, your ears should kick up and be like, let me pay attention or ask more questions. And then weight and the modifiable things like diet, smoking, and alcohol. So race is also something that is important when it comes to developing colon cancer. Again, like prostate cancer, for some reason, the Black community is affected. I do find that the Hispanic community is also affected significantly when it comes to early diagnoses of colon cancer. We haven't really figured out why. We just know that these are the stats, that Black Americans are 20% more likely to develop colon cancer and 40% more likely to die from it. So it's double death compared to developing. So it's really, really bad and also unexplained. Part of it is that we don't get screened, but I think part of it has to do with genetics and things that we as a medical community has not discovered or figured out yet, and we're still working on it. And then back to the whole basis of this talk, Black men have the highest rates of colon cancer. So not only are the men in here at risk because they're Black, they're even at higher risk than the women in here. So we have to pay attention to our health, we have to get screened. Knowing your risk, I know you guys know who this is. He was one of those, that actor who died early because of colon cancer. I think he was in his 40s or around 40. And that's something that is puzzling to us. Why are we seeing so many cases of early diagnosis of colon cancer in young people, Blacks and Hispanics especially? My colleague texted me last week. He was on the inpatient service, and he goes, I don't know what's going on. I have 2 patients on my list, both 36, both with colon cancer spread everywhere. We are looking into it, we're doing research, but we can't identify. Some of it, they say it's environmental in the food that we eat and the places that we live as a community, but we haven't been able to fully put our fingers on it. It's estimated that by 2030, colon cancer rates in people under age 50 is going to double. So that's why the age went from 50 to 45. I was talking to one of my friends, he's one of the doctors who does the colonoscopies, and he said to us, I think when I'm 40, I'm going to get a colonoscopy, and you guys should get one too. And that's based on what he is seeing every day. So I wouldn't be shocked if in the next 5 years, this number becomes 40 and drops down from 45. All right, how do you get screened? You have options. The most reliable is the colonoscopy, where they go in with a scope and they look at the entirety of the colon. And that's because not only are they seeing what's going on, but if there's something there like a polyp, they're able to grab it at the same time and send it to the lab to test to see if it's cancerous. The stool tests are also very popular and common. They're different types. Some look at the DNA, some just look for blood. The ones that look at DNA, meaning they're scanning the stool to see if there are any potential cancer cells, those have been found to be highly reliable. The thing is, if you have a positive stool test, that's not a diagnosis by itself, and you need to go get a colonoscopy. With the stool test, you have to do that every 3 to 5 years. The colonoscopy could potentially be extended to 10 years. So it's a conversation that you should have with your doctor as to which screening test is best for you. There is no right answer. Even though the colonoscopy is said to be the gold standard, we have had cases of people who had colonoscopies and a few months later they had cancer. And we've had where the stool test detects something that the colonoscopy can't pick up. So there's no right or wrong. It's just a discussion and a risk assessment that your doctor has to do for you. If you have a family history of a close relative or you have one of those syndromes that we talk about, then the colonoscopy is the test that you should get. Oh, well, that went fast. Almost there. And we talked about this. You get the test, positive result, colonoscopy, prevention, things that we could do. And this applies to not just colon cancer, but to every cancer. The aim is to move more. We need to exercise. And that could look like walking for one person, going to the gym for another person. But we do recommend that you get 150 minutes of moving every week. So that could be 30 minutes a day for 5 days, or if you want to lump it together and do 50 minutes for 3 days, that's also acceptable. Eat more plants, so vegetables, beans, fruit, and whole grain are important, especially for colon cancer because that fiber gets things moving. And then avoid smoking and tobacco. You're gonna say we don't do that here, but I know you have friends and family who do that, so it's something to discuss with them. This is something I get a lot. I do see a lot of patients from the Caribbean and South America and Africa, and the recommendations that are given for people to eat fruit and veggies are not something that we want to adapt because it doesn't taste good. So you should eat the fruits and veggies that you are used to because you're more likely to enjoy those and keep doing that. I know based on the doctor you go to, they're like, eat lettuce and eat this, but you typically don't eat that. But you have callaloo and you have all those other things that we cook with the saltfish. Add more callaloo to the saltfish instead of more saltfish to the callaloo. Your beans and your lentils, we should eat those. Eat your mangoes and your oranges and your guinep if you get it on the street. Just eat the things that you enjoy. And a lot of times you could, with the internet and with AI, you could get your recommendation from your doctor and say, hey, how do I adapt this to my culture, my lifestyle, to get the same benefits without compromising? And a lot of people here, you might say, I'm too old for all of that you're talking about. But you have nieces, nephews, daughters, sons, you use them as resources. The 5-year-olds are very good at using the tablets and the phones, so you utilize them and say, hey, can you get me this info? And if you're not sure, when you go back to your doctor, say, these are the things I'm considering. What are your thoughts? And things that you shouldn't eat and should cut down on. We don't like this, but processed meats, frequent frying though, that might be an issue that we have in this community because we fry the chicken, we fry the plantain, we fry the fish. I'm not saying you shouldn't fry it. I'm saying we should lessen the amount of fried foods that we eat. So some days you might bake the chicken instead of frying the chicken. Other days you might boil the plantain instead of frying the plantain. The air fryer is a good alternative for those who are willing to give it a try because it removes that excess oil that you would otherwise use if you're doing a pan frying. Sugary drinks. So I know my grandma made some of the sweetest drinks that you could ever drink, and it was good. And people would take the same amount and add water to it and say, oh, it's not as sweet. The issue is, even if you split that bottle in two, you're still drinking the same amount of sugar. So if you're gonna buy the soda and say, oh, well, I'm gonna dilute it, but you end up drinking the whole bottle that day, then it's defeating the purpose. So what you could do is take the bottle and split it in two. Instead of drinking the whole thing today, you drink half today, half tomorrow. That's a start. I'm not saying avoid it. I'm saying cut down. Drink more water though, because it flushes the kidneys, it flushes the system, and overall it does help with prevention of cancer because you're getting rid of the toxins that would otherwise change the cells into becoming cancer cells. Very large portions of food. I know as Caribbean people, we like to sit down, especially on a Sunday evening, and we just eat like the world is ending. And you have a plate that is 90% rice. Well, let me change that. Sunday might be 80% rice, 15% chicken, and maybe 5% veggies. We have to change the ratio. We have to cut down on the rice, eat more veggies, and eat more protein. So those are ways that we could actively try to help ourselves. They aren't foolproof, and it doesn't mean that by doing these things you won't get cancer, because I see healthy people who do everything right end up getting cancer, and that goes back to the genetics portion. But by doing these things, you are cutting down your risk significantly, because if you have the genetics portion working against you that's already high, there's no need to add these things to make your risk higher. Back to men, common reasons why men delay. Being tough and saying that I feel fine, not wanting to admit that something is wrong even when you don't feel fine, because you're putting on this front that men are supposed to be tough, men are supposed to be fighters, we shouldn't show weakness. That is the furthest from the truth, because when you are sick, my male patients are probably the weakest, most sobbing, crying patients when they're sick. So why save that for when we can't do anything or what we can do is little? Go ahead and remove that barrier, that image that, oh, I have to be tough. We need to, as a community, remove that stigma so that, one, men in general don't feel ostracized or feel less than when they do seek help. The other thing is I'm too busy. And I get that because you're working and then you go home, you have things to take care of at home. And when you do get time to do anything for yourself, you're going to whatever country you're from, or you're going to work on a project in the yard that needed to be done. And you say, I'll go when I have time. The issue is you will never have time. You have to make time for your health. And the last one, which I get often, is I'm afraid. And the way I think about this is if you have something that's wrong, being afraid of finding out and ignoring it doesn't change the fact that it exists. All you're doing is delaying the inevitable. One day it's going to declare itself that something is wrong, and at that point it's going to be far more advanced than if you had sought help earlier. And what this means is that the treatment approach is going to be way more intense than if you came in earlier. So being afraid, I get it, because if you think if you don't know, then you don't have to deal with it. It's true, you don't have to deal with it right now, but you will deal with it in the future, and it will be a lot more of a burden to you at that time. Getting checked is a strength. By doing that, you have more choices. So going back to the prostate cancer, if someone gets screened because they have a high risk, and we find that they have the cancer that's confined to the prostate, right then and there, I'm having a conversation with them, like, well, it's based on what you want to do, what side effects, because we could do surgery or we could do radiation. When they show up to me and it's in the bones, I'm like, this is the plan, this is the best we have for you, and this is what we have to do. By then, your options have dwindled down and you're getting things that are mainstream, one, with a lot of side effects, and there's no going around it. So getting checked early creates this option for you, and it protects you as a person, but it also protects your family, because cancer in general is costly, time-wise, financially. It's very expensive. Even if you do have insurance, you are spending a lot of time with the doctor, the more intense your treatment is and the more advanced your disease is. So take, for instance, my prostate cancer patients. If they come in early, or we find them early, we treat them with radiation, or we do surgery, and sometimes they get a little bit of hormone therapy, and maybe I see them every 6 months, 3 months. But when they're more advanced, I start out seeing them every 2 weeks, then 4 weeks, then the longest we could go is 3 months. If they're getting chemotherapy, they're coming in every 3 weeks at least 6 times. So if you count all those visits, that's a lot of missed work. And depending on what you do for work, you might not be able to get reimbursement or coverage for that. So that's lost income, not free, just for you, but also for your family. And then that lost income adds financial stress, that adds stress in general, and that's not helping the cancer, that's not helping your family, that's not helping your kids. And it's just a spiral of events that could potentially have been avoided if we walked into the doctor's office and say, hey, let's have a conversation about this. What's my best approach at this point in terms of getting checked? Do I need to get checked, and so forth? And even if you had cancer at that time, you'd have gotten treated and we'd have forgotten about it. There are patients I see once a year. I'm like, hey, how are you doing? They're like, no changes. We get a scan. I'm like, looks good. I see them in a year again. So homework, I like to give homework. 1, learn your family history. 2, talk to your doctor, call them if you don't have an appointment for a year, say, hey, I want to come in and talk about this. And then most importantly, as a community, we have to support and encourage each other to pay attention to our health, to get screened, to take care of ourselves, because not only is bad health affecting you as a person, it is affecting everyone as a whole. Know your risk, notice changes, get screened, encourage each other. All right, so final thing I think is you're saying, I don't know what to ask my doctor when I call them. You could say, what screening is right for me? When should I start screening based on what you know about me or what I've told you just now? How often should I get screening? And does my family history affect how we approach this? That's it.
Before we give the doctor a big round of applause, we would like those with questions from what you have learned just now. I know there's a lot of burning questions, especially for us men. A lot of us don't even have a primary care doctor. Show of hands, especially men who have a primary care doctor. Don't be shy. How often do you visit your primary care doctor? So we might have them, but do we actually visit them? That's the issue. So the mic is available. Please feel free to come and ask questions, because now you have an opportunity to ask everything you would need to know about what might be affecting you or what you have just learned. So I would like everyone to take some time, think of your questions, come and ask the doctor politely, and then we can have a conversation. The mic is there, just stand one at a time.
Hello, Doc. Beautiful presentation. I do enjoy the information, very informative. My question is, though, how do you know if the prostate is enlarged? And you never really touched on that. How do we check it?
So the symptoms that we talked about are issues with peeing, blood in your urine. So if you can't initiate or you're peeing and it's still dripping when you're trying to stop or you're going often, but to objectively say that it's enlarged, one of the most common things that we do is the MRI, because the MRI not only tells us that there's something abnormal on there, it tells you that what the size is, and we know what's normal compared to non-normal.
Good evening, Doc. Years ago, we used to do this test. You alluded to it earlier, where the doctor stick him finger up your rectum. And you know that men on a whole. It's so painful because we know that things supposed to come out, nothing is supposed to go in. Now listen. How effective, you spoke on it, but I need more clarity. How effective is the PSA, the test, the blood test? How effective is that?
So it's a very sensitive test, but not super specific to the prostate. What I mean by that is if it's high, then there's likely something wrong. But like I said earlier, it's not a diagnosis. The PSA just tells us that we need to do something else. That something else might be exactly what you described, which is usually the quickest way to know that something is wrong. So the urologist might go straight to that when you go into his office after we realize your PSA is always high. Because by doing that, they feel the prostate to see that it's irregular. If it is irregular, then we know for sure that there is a 90% chance that there's cancer there. The MRI is something that we could do, but there's a time lapse with that, and it's also costly. And if you don't have insurance, sometimes, even if you have insurance, sometimes the insurance will say, oh, we don't want to do this, did you try this instead? And there's a lot of back and forth. So some doctors still do the what we call digital rectal exam, but others go straight to the MRI. The PSA, to answer your question though, is just a screening tool to say something is wrong. We need to figure out that something is wrong. Once you have prostate cancer, however, we use that PSA to trend how you are responding to the treatment that we're giving you. And at that point is very, very, very accurate because we know what you started at and we know what you went to when we complete the first phase of the treatment. So if we start seeing it go up, we know that something is wrong again.
I noticed that in recent time they said there's a new test out, but they're saying that it's expensive and most insurance don't cover it. Do you have an idea what the test is?
So you're talking about what we call the PSMA PET scan, and you're right. So it's usually done when someone has a confirmed diagnosis of prostate cancer, and we want to know how far it's spread. Back in the day, we'd do a normal CT test, a CAT scan of the belly, and then we'd do a bone scan. So those are 3 tests. This one test does all of that with a special dye that they inject, and it basically lights up, and we're like, okay, wherever it's lighting up, you have not only cancer, but prostate cancer specifically, because it's a test that targets areas that have high PSA. The issue is that insurance companies do not want to pay for new things. I've spent cumulatively hours on the phone arguing with them to get this for my patients. So, yeah.
Yes, thank you, Dr. Hoylett, for a very informative presentation. My question is, 1, would you consider men who are in the senior population, relatively active, healthy eater, to be more at risk for prostate and or colon cancer? And 2, would you consider someone who consumes a lot of flesh food to be more at risk than the non-flesh food eater?
So to the first question, yes. Age by itself is a risk factor for both colon cancer, prostate cancer, and cancers in general. And the reason for this is that as you get older, your cells struggle to correct themselves. Because if you think of it, your body's always making new cells. And in that process of making new cells, something goes wrong. It always goes wrong. But your body is able to catch that and get rid of the bad cells. Cancer develops when your body is not catching those at the correct pace, and they're allowed to accumulate, and then you create tumors. As you get older, that process kind of weakens, and so age by itself is a risk factor for any cancer. So that's to your first question. To your second question, it depends on what that meat kind is. We find that red meat makes you more prone to developing cancer as opposed to chicken and fish. The real data on it, it does show that it increases it, but that by itself is not enough to say someone shouldn't consume it at all. That's why we talked about balancing the diet, getting meat, because you do need that protein, whether it be vegetarian or from an animal, for the other functions of your body. So you can't ignore it completely, but eating a lot of red meat, yes, does increase your risk of getting cancer.
Thank you.
Good evening, Doc. Happy for this program that we have here. Whatever you are discussing, I myself, went to my regular doctor, and she says to me, I'm going to send you to do a MRI. And the result was that my prostate was getting large. And she says, I'm going to send you to a specialist. Send me to a specialist, and getting my treatment. The doctor says, one good news is that the prostate is, your prostate is getting large, but is not cancerous. I continue to get my regular checkup, and One of the time I went to him and said, this is not good, because the PSA showing that the blood, something is wrong there. He says to me, well, don't worry about it. I can treat it. Began to treat it, still no good. He says, well, I'm going to send you to do a procedures. And I don't know what it does. He said, well, the procedure that you have to go through, we have to put you to sleep because I don't want you to feel any pain. Well, I made arrangement for the procedures. I go through the procedures, put me to sleep. When the procedure was up, I don't know, maybe they do something. They put me to sleep. And I don't know what it does, but when they finish, they call my name, Herman, you're ready to go. And I'm saying this that from I do that, it's about 7 years now. And I stopped from work maybe 2 months, and from 2 months, I still continue to go to work 5 days a week. I still had to do my regular checkup, give me some medication. Just Tuesday this week, he said he had to give me an injection. The injection is lasted for 6 months. This Tuesday gone, I went to get my 6-month injection. They stick me right in my stomach here. And this, I asked the nurse, how long did this would take? 6 months. Another 6 months, I have to do it all over again. And every day, I have to take, it's just like my blood pressure tablets. I have to take my tablets every day. I have to take my medication every day. And I'm happy for that. I'm feeling good. Give God thanks.
Thank you, Brother Lewis. So, quick summary of what Brother Lewis just described to us. What it seemed like was that there was concern for early prostate cancer 7 years ago. They treated it minimally, and they were concerned recently that it's worsened. And now they're giving this hormone therapy every 6 months. It's every 6 months or 3 months, depending on the dose that they're giving. And then there are pills that we sometimes give to help with the treatment. So this goes for the rest of the men in here who might be afraid to get checked. The treatment is not always as bad as you think it will be. So it's better to know than not to know and wait till it gets worse.
So the injection that they gave me is, they call it Elogar. And what I'm saying, I'm a living witness, man. You don't have to fear. You don't have to fear. Go and get your checkup before it's too late.
That's the message right there. You don't have to fear. Just go get help.
Yes, doctor, thank you very much for your presence here and for giving us all this stuff. Because I've got experiences that I could ask you about and that I've experienced definitely about cancer, right? So I went to see my primary care doctor and he said my PSA count was going up. But I didn't know what that means. He didn't take it that seriously. So when I went back a couple months again after that, he said, this thing is going up. You got to go to the cancer department, oncology department, right, down at East Chester Road. So I went there and started to do some MRI and stuff like that to see how far it's going. So it's going to the wall, like it could go out into the body, right? So I don't know if they're trying to put fear in me, but so they say I should do. One doctor said you're gonna remove my testes, right? You know about that? Remove your testes?
Keep going.
Yeah, so I'm like, what? My testes? That sounds crazy, right? There must be some other way. So I went across to another doctor, and this doctor is saying, well, I'm an expert at this. I do this all the time, you know? And he's telling me what's going to happen. I'm going to have a bag or whatever, and he's going to... But anyway, I go to that doctor, and he suggests to me radiation oncology, right? And that's what I chose. And then when I went to Montefiore and started to do the radiation, the guy there, who does the radiology guy who does the radiation says, man, I'm happy that you do radiation instead of chemo. He said it's better. And everything I did, weeks of it, and after it, I was a mess, you know, like fecal incontinence, a lot of peeing on myself, all of that for weeks or months, you know what I'm saying? But before that, though, they gave me like almost 11 months of injection in my stomach. And when I went to the department where they wanted to remove my testes and told them, no, I'm not going to choose that, they were shocked. And so they were well prepared and they were going to use it and do tests on it. So it never happened. And sometime I think you could defy the doctor, because suppose I had gone with that. I don't know, but anyway, that's what happened. And I've recovered now. And when I went back to my doctor, my PSA count went all the way back down to normal. And he said, yo, that thing is gone, even though you never know if it come back, but that's what happened right now. So that's...
So I want to say he didn't mean to say testes, and instead he meant to say prostate.
Oh, I want to remove my prostate.
Yes.
Oh, yeah, my prostate. My testes, he said, prostate. Which one?
Just clarifying that.
Prostate?
So he wasn't wrong in suggesting removing the prostate.
Yeah.
So that's what I mentioned when we said at that stage you have options. One of the options was to get surgery where they take it out and that's it, and you forget about it. The other option was to get radiation along with the injections that you got for a short term. There's no right or wrong answer. They're not better. One is not better than the other.
Oh, really?
It's just the side effect profile. Which side effects are you more willing to take? We find that the outcome itself was the same. So if you have gotten the prostate taken out, it would have been the same overall outcome, meaning that your life expectancy would not change. So neither doctor was wrong. It was just an approach from different perspectives, because you went to a surgeon, he's going to tell you, let's do surgery. If you go to a radiation doctor, he's going to tell you, let's do radiation.
Oh, okay. So, well, the surgery is very uncomfortable, though.
I mean, the radiation is uncomfortable. You just described
Yeah,
it.
because while I'm laying and he's doing that, because I like to drink a lot of volume of fluid before, and sometimes you can't hold it, so you pee right out there on the bed. So all of that, yeah. So, but that's easier than the surgery.
So it depends on what. So this is for the general public and the men. We don't argue that one is better. They're different. The surgery, you go in and it's done and that's it. The radiation, you have to go multiple days per week for multiple weeks. So you're taking more time off back to back. So it's, what do you rather do? Do you want to go under surgery and get anesthesia and be done? Or do you want to go in every morning at 8 a.m. for the next 5 weeks and do the radiation and get the injection for 18 months? No right answer. It's a personal preference. You did the radiation and it worked, which is awesome. That was the goal. But if someone else says to you, I want to do the surgery, you shouldn't discourage them, because it's not worse than the radiation.
One more thing, doctor. Does the removal of a prostate create all those fecal incontinence and all the same? Like, okay.
Yeah, but usually both are temporary. That question, surprisingly, the radiation has more of a negative effect on the sexual function than the surgery, and that's because the radiation comes with that injection. And what that injection does is that it reduces your testosterone to 0. So if you don't have testosterone, we're effectually sending you into a male version of menopause. So you're going to start having hot flashes, decreased desires, and decreased energy. Some people have the mood changes, but not as much. But that's something that you see with the radiation because you have to do the injection. There's still a risk with the surgery, but I see it less often. The location of the radiation itself also does. Back to his comment about the testes, back in the day, they actually used to do that, but the injection replaced that surgery.
So we're going to take one more question, and we're going to have 2 songs, then give the doc a break, and then we have more questions after, okay? You sure? Okay, we carry on.
Yes, my question to you, would you say that waking up like 4:30 in the morning to urinate, would you classify that as frequent urination during the night?
So if you are waking up at 4 a.m. only at this stage in life, you are doing well, okay? Because the rest of us do wake up at some point. So no, I wouldn't call that frequent urination.
Yeah.
If you told me you're waking up every 2 hours, that would be frequent urination.
No, what I do is I try to consume most of my water during the day and do not drink any water, say, after 7.
You're still gonna pee, that's normal.
Yeah.
Yeah.
Another thing you talk about, constipation, like I've talked to quite a few men within my age group and younger, and what they complain about is the constipation. I was scrolling through Facebook, and they're saying that there's a thing like I would say a tightening in your rectum area that can cause not using the bathroom quite frequently.
So they're referring to the sphincter, but that by itself doesn't necessarily cause constipation unless it's malfunctioning, because we all have that. That's how you prevent yourself from going when you don't want to go. Very few people have an issue with that in itself. Most causes of constipation are either diet, lack of fiber, dehydration, and then those things being common, and then you start thinking about things like cancer and so forth. So it's hard to say, but it's a conversation to have with their doctors to see what is most likely causing it. They could try the over-the-counter stuff like the Miralax or the Senna and see if it helps, and if it doesn't, then it's time to seek help.
And the last question, your PSA level, at what point would you call it high? Like, is it 3.1 or 4.5 or whatever?
So there's no right answer. We look at the trend. By textbook, the number is 4, so anything above 4 is high. But if you were 1 this year, 2 next year, and the following year you're 3.9, I'm concerned because you're doubling your PSA too quickly. So even though it hasn't hit the 4 mark, something is triggering it to go up from normal. So we don't necessarily use the 4 as the gold standard per se. It's just what the lab calls high. So say, for instance, I had a patient who had prostate cancer. He was thought to be cured. They sent him to me. I was following him, and his PSA went from 0.9 to 2 point something. You look at that and like, oh, it's normal. But it wasn't normal for him because he doubled in a short time, which means that there's a high chance that the cancer came back. So to answer your question, strictly by the textbook 4, but in all reality, we are looking at the trend.
And one more. Does abdominal exercises help you with your prostate, like, bending forward or at the gym? Like, I go to the gym 5 days a week. And
So it doesn't help with the prostate in itself, but it helps you in general because it is exercise. And any exercise, strength training, aerobics, running, it is part of being an active and maintaining an active lifestyle. And that by itself decreases your risk of cancer in general. But abdominal exercise in and of its own doesn't really do much for the prostate.
Sure.
But you should keep doing it.
Thank you, thank you.
Yes, doctor. Thank you again. Well, so when I had my prostate issue, there was a friend that I have the same problem with me, right? He had cancer with prostate too. So he went and did radiation like me. And one day he went to Jamaica and he was at the National Stadium and he started feeling sick, started feeling headache. And he wasn't feeling too good, but he came back up here. And eventually he ended up going to the hospital later on. He wasn't checking on himself. Like, I would go and check my primary care doctor, but it seemed like he wasn't doing that. And then eventually, later on, he had back pains, then he ended up in hospice, and then he died. He had prostate thing like me too, cancer, and he had radiation too, but I don't know what happened, why his own deteriorated like that, you know what I mean?
That's a good point. And it just goes to show that cancer is not universal. So you might start with what looks like the same thing, but your disease operates differently. And that's why every patient is different. Because we don't just look at what we treated you with, we look at what your cells look like under the microscope, and we do a risk stratification. Are you low risk, high risk, intermediate risk? And so you might have been an intermediate risk and he is high risk. It means your disease will operate differently even though you got the same treatment. You will be more likely to survive than he is. The other issue is the follow-up. If he wasn't getting adequate follow-up to trend his PSA and there was a lapse in time, then what they would have caught earlier was missed, and by the time they did catch it, it went to his spine. For the record, even with prostate cancer, even if it spreads to other organs, there are very good treatments available to get rid of the cancer or to control the cancer. But again, it doesn't mean that everyone is going to respond the same way. Some people I give that treatment, I check them in a year and there's no evidence of the disease. Other people I have to escalate to some other sort of treatment, even though we started with the same thing. And that's because cancer is not a one-size-fits-all. And that's why when someone asks me, do you think they have the cure for cancer and they're not giving it to us, I tell them no, because that would have to be something out of this world that could switch to fit everyone's type of cancer.
Good evening, Doc. Good evening, Doc. I am enjoying your presentation. My question is, when I was younger in the country, I would see like men would walk around with bags, and they would call that bosun. Right, bosun. But in these last days, I've been not hearing that name, I've been hearing prostate. Is it the same or?
Can someone describe bosun to me, and I'll tell you.
Wait, one person first.
The scrotum gets That's a good question. I don't know. It probably is some sort of cancer. It could be kidney, it could be prostate, it could be bladder. It could be anything that's preventing that outflow, and then it causes backup and it expands. So Sister Mary is asking about hernia and how it differs from cancer. So what the hernia is that you have your intestines that is confined.
One voice, please. The doc is up the floor. One voice, please. Thank
That
you.
is confined to the abdomen, but sometimes the walls that are keeping it intact, there is a weak point that opens up, and so whatever should be in starts to push out. That's a hernia. So it's not cancer, it's just a malformation of your normal chest, belly wall. So something pushes, like you have a bag of, I don't know, worms, and then there's a tear in the bag and it starts to push out. That's a hernia. Yeah.
From what I know about this thing that they call boson, it is a situation where your testicles, the scrotum on a whole, it is swollen. And I don't know what happened to it, but it used to get so big. But I've noticed in the past years, I've not seen men suffer from it again. But it is something, sometimes when you look on the poor man, the whole eye is so big.
So it's either what we call a hydrocele, which is just, it's not cancer. It's just a swelling of the testicle itself for some reason or another. Or it could be what we call epididymitis, which is an infection. It's hard to say which it is. But when you have a swelling in that area, it compresses the vessels and what we call lymph nodes. And so the leg is not able to drain properly. And so you start having swelling of the legs as well. Highly unlikely that it's cancer if it gets better after a while.
Hey, Doc. Good evening.
Good evening.
How dangerous soybean product do to man? Second, how often a man supposed to detox in 1 year?
So the first question is a loaded question, and I'm gonna tell you what I know. There have been conflicting studies when it comes to soybean because there is an increased amount of estrogen with the soybean products itself. So it can have negative effects. I don't know exactly what those effects are. There could be some related to cancer, some related to just balancing your own hormones. But it's hard to say. What I do say is that they recommend against eating large portions of soy products, including the milk. So it's something for us as Adventists, because a lot of us do eat soybean products or veggie meat. It's an ongoing study. There's no clear definition as to how much is too much. Everything in moderation. I don't think we should make our diets primarily that. If you're going to be vegetarian, then there are other beans and so forth that you could eat to get your protein as opposed to just consuming the processed soy. So that's your first question. To answer your second question, I simply do not have the answer to that one because I don't think that is something that is published or studied enough for me to give you an objective answer to say 2-3 times per year. I don't know.
Okay, I appreciate it.
Please, you have to use the mic. We have persons waiting. If you have a question, you come and ask your question. No, not you. Sister Francis. Thank you. Persons are waiting.
The colon cancer or the colon test, my primary care doctor I had before, he believed in doing a colonoscopy every 5 years. The one I have now say every 10 years. How do you know the difference? Well, if you wait for 10 years to do another colonoscopy and something happened in between, how do they detect?
So it's a good question, and I want to assume your first PCP had a reason for the 5 years. The times that we do that is when you have a colonoscopy that's not completely normal. So if they found a polyp or something else that they need to pay attention to, that might say come back in 3 years, come back in 5 years. And then they'll have you do 5 years for a while if that's what they decide. If you do a few 5-year exams and they're normal, then they extend it to 10 years. So it could have been that you transitioned from PCPs at that point when you could also transition from 5 to 10.
But every time I do the colonoscopy, it was always normal.
So then,
But yet still, he still believed, in doing it every 5 years, which I don't mind. Because I think waiting for 10 years, what if something happened, like, at the end of that stuff?
So I think that was your PCP transferring his anxiety onto you, which is not uncommon. We do see this. However, you've also proven why the 10-year works, because you got 2 5-year scans in that 10-year and they were negative. So it means that you underwent unnecessary screenings for no reason. And it just goes to prove that these guidelines that we have do work because they are well studied. Yes, there's the one-off person who we would have caught cancer if they did every 5 years, but we look at how many people do we have to do 5-year exams for to catch one. And that's where those numbers come from. So for you, you went through unnecessary testing, time off from work, and anxiety, because for every colonoscopy that you get, you sit around wondering, what will it show this time? And that's unmeasurable effects of the healthcare system that we do try to avoid by following these guidelines. So I would stick with your current PCP who says 10 years. Of course, if you have symptoms of bowel changes or blood in the stool, then you could always go back for what we call a diagnostic colonoscopy as opposed to a screening colonoscopy.
Hi, good afternoon. So I have 2 questions. The first one is, well, it's not directly, well, it is, okay. Like, what resources do you think could be put in place to make sure that men are comfortable enough to be like, okay, I'm sick and it is the best thing for me to go and get help?
So you're now touching on what we call health equity. And this is something that I've spent a lot of time focusing on, especially with my affiliation with Sloan. We've started this new health equity conference. And to answer your question, some of the things that we're working on is meeting the men or the people in general where they are. So things like forums like this, one of the initiatives that we see that works a lot is engaging men in the barbershops, because we find that that is a safe space for men and is a space where they're more open to discussing not only what's wrong with them physically, but the emotional aspects of those issues. And so there have been many programs where we interact in that space. We give brochures in that space. We enable the barbers themselves to start these conversations so that men feel more comfortable reaching out and getting care. There are many more things that we could do and should be doing, and some of us are working on it, but there is a huge gap that needs to be filled.
Okay. Second,
And working with the church and the health department of the church is one of the ways to reach not only the men here, but the men around us. The health fairs that we do have, those do have an impact also.
all right. Second question. You were talking about how sugary drinks is one of the bad things that you shouldn't do. So I just wanted to ask, what about diet? Like, they have Diet Coke and Diet Sprite, Sprite Zero. Do those work better?
In all honesty, those are using sugar substitutes, and those do have effects as well. I'm not 100% sure what those are in terms of statistics, but we know that there are certain types that do increase the risk as well. The benefit is that it reduces your risk of diabetes and direct impacts of high sugar, but because they are processed sweeteners, they might be increasing your risk of cancer and so forth. So that's why the recommendation is to drink more water. Yeah.
So just no soda.
I'm not saying no, I'm saying cut down. So if you
Okay.
used to do 2 cans a day, start doing 1. And then if you used to do 1 a day, you could do every other day. It's just balancing. I'm not saying never do this because then you're not living the life that you
Right.
would potentially view as enjoying. So it's temperance. Yeah.
Okay. Thank you.
Hi, good afternoon. I have 3 questions. You spoke earlier about issues with urination, and I just wanted a bit of clarity when it comes to that. I have heard people say that when a man goes, well, I know when a man wakes up in the morning, it takes a little bit of time before when he goes to pee for the first time, it takes a little time before it actually comes out. But I have heard people say that when there are prostate issues, sometimes it drips a little, or maybe if his stream used to go further, it probably drops back a little bit. And there's drip, 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 drip. And when he's finished, it just drips. So I just wanted to, because I'm sure some of the men here would want to know that.
So I'm gonna list them. So one of the things that we do notice is that you cannot start the process. And that's because if you think of the picture that I showed you where the prostate is wrapping around that tube, if you have a hose and you clamp it,
Yes.
right? And you have a bag at the end that you're pushing water, it's going to be hard to release that clamp to start the process. So that's one. And if you do release that clamp, it doesn't mean it's going to stay open completely. So you have to keep adding pressure to get the water out. So that's where you have the dripping, because each time they go, you get some out, and then it starts to run off, and then you have to do it again. So they're straining to pee. If you're straining to do something, then you're adding pressure to the walls, and that's where you have bleeding. So blood in the urine is something that we see. But even then, you're going for a while. You're pushing that water through the hose, and you think you are done because you've been there so long, and you stop because the pressure in the bag of water has died down, but the bag isn't empty. You think it's empty. You can't see it. So you walk away. But then it fills up back quickly because it's not starting from zero. So you're going into the bathroom and doing it again. That's the urinary frequency that we see because you're not completely emptying. You have to keep going to the bathroom because the bladder was never empty. And so it just takes a little bit more fluid to build up for it to trigger you to want to pee again. So that's urinary frequency that we see with that. And then issues with stopping is the fact that when the bladder or the bag in the hose gets full and it starts pushing on its own slowly, it just continues dripping through that clamp, the small amount, but it's not much because a lot can't come out. And so it's just constantly dripping and they find that they might be wet. So those are the main symptoms. It's frequency, it's issues starting, issues stopping, it's dripping, and it's blood. Okay?
Thank you for that. My second question, what is the function of the prostate in the body?
So the function of the prostate has mostly to do with the sexual functions of the body. It produces things that we need for reproduction from a male perspective. And that's why it is affected so much by the testosterone, because its function is driven by that. And so the cells themselves that are forming cancer are primed to react to testosterone. So to answer your question, it's more of a sexual function than anything else.
Okay. My last question, when it is removed, because I know sometimes even if a man may have symptoms and he may be afraid to go get help because he may think that he may have to get it removed and he's concerned about what the effects will be if it's taken out. So what are the effects of having your prostate removed?
Most of the times people do okay because they're older and their sexual function has already declined.
Okay.
The other aspect is sometimes you could find that things go backwards instead of forwards in terms of their semen and so forth, or the consistency of it changes. But it's usually not something that they notice significantly. What they do notice, though, is the effects of the surgery itself from the nerves and the other areas around the prostate that were damaged from the procedure. And so you have issues with incontinence where you can't control your bladder functions because there's injury to the nerves. Really, now that we have what we call minimally invasive robotic surgery, those effects have been minimalized. But some people do have them briefly and then it gets better. And then you're also affecting stuff with the rectal area. So you get diarrhea. Those are the main effects from the surgery. The sexual function also declines briefly after the surgery. Same goes for the radiation. So for some people, they recover in a month, some 6 months. The rare person is not able to recover at all. And then if they're getting those injections, then they might never have that function again. And this is important for the women in here who have husbands who have prostate cancer, because we find that a lot of the frustration is on your end because your husband does not have a desire at all because that is gone with the lack of testosterone. And so now you are left bearing the burden. So it's something to note.
Okay, thank you so much.
Good evening. Excellent presentation, Doc. I came with one question, but then two came along. One, does anxiety can cause you to urinate frequently?
Yes, because it's stress. And stress affects your, what we call sympathetic system, which triggers the bladder to release urine. So the bladder wall is a muscle that's controlled by nerves. And if the balance of your nervous system is off from your anxiety, then yes, it can. But not because something is inherently wrong with you, it's just the anxiety itself is triggering a response.
Okay, my next question is it a myth or is it true? Does acne affect your prostate?
I don't know
well,
about
I don't know if this is the can one or the one that you picked from the tree. I always hear people mention of it, and also tomato. Does any truth in it, or is it just a myth?
I can't confirm or deny because I've never heard it.
Oh, you never heard it?
But it's something to look into. I mean, are they saying that it's protective or it's negative?
Negative.
I mean, I don't know, but it could be because the prostate cancer rate in Jamaica is higher than most places. So it's something that we definitely need to look into. I don't know. I really don't know. There's not enough data that I have to say.
All right. Next, myth or truth? Does regular ejaculation helps the prostate?
It's not a myth. It's the truth. It's not a myth. Yeah.
It is the truth. Okay, wives.
Because there's buildup.
Doctor, we want to We want to thank you for your contribution here this evening. And from what I gather, this is a product of the church contributing to the well-being of the church, and a young person too. And so I'm saying the church has to find ways of equipping and motivating young people so that they can achieve their goals and at the same time have a firm understanding that they should contribute to the well-being of the body. You said something which sound, kind of unimportant, but I think it's most profound. The fact that you said that if we knew the history of our family members, it might make our situation better. We would know more about ourselves. And there's a quote in the Bible that says, we should not hide ourselves from our own flesh. And I think that, I suppose we are very good at hiding ourselves. And so I'm saying, let's begin to think about researching our family history. Let us get a record going, a documentary of the ailments of our at least close relatives, because that would be more helpful to us than maybe we realize. Lastly, when I was going on the bus, I saw the shrub in the walkway. They're so luscious. And I'm saying, wow, if we could only eat these. And since you spoke about vegetables, and we gravitate to the ones we love and so on, are accustomed to, is anybody doing any serious research on the benefits that we could get from some of these plants that look so, we just call them?
I missed the last part of your question.
Oh, I'm saying the shrub that we see growing all around the place, looking so luscious on the roadside, is there any serious scientific research being done to uncover what nutritional benefits?
All right, so I think you said three things. The first thing is involving the young people, which I agree with, and it's something we as a church have to pay attention to because there are a lot of young people who go out and they come back with knowledge and they're not able to act in roles in the church to impart that to better the church. So I agree with that point. The second point is knowing yourself. We talked about that, full agreement. Your third point, I can't say I agree with because we have enough things that are proven to be able to eat that are safe, and we shouldn't be going out there looking for things that could be of detriment to us. So if science discovers something that we weren't eating that we could eat, then good, it might help with food shortage somewhere, but we shouldn't start picking things and figuring it out for ourselves because that could also be bad.
Yes, sir. Good evening. I enjoy your presentation. But back to the hockey. I heard a doctor said the hockey have a saturated fat. And they said early on that Jamaica men have the most prostate, if my mind's serving me right. So.
Your saturated fat statement is true. Ackee is a fatty fruit. And so if we eat too much of it, we're at risk of increasing our triglycerides and our cholesterol. Doesn't mean that you shouldn't eat it at all. It comes back to balance. And the second part was, what again? What did you say? The second statement you made?
You said Jamaican men.
Oh, yes. So that is something that is studied and well proven. The age for screening in Jamaica is actually 40 as opposed to 45 because we have so many men who are diagnosed with prostate cancer. The issue is that as a country, they're not equipped to deal with the increase or the incidence of prostate cancer there because we simply do not have the treatments readily available. And so what happens is I see a lot of patients in my office who are from Jamaica and the Caribbean as a whole who come here on the plane, land at JFK, present to the emergency room with back pain, and we find that it's prostate cancer. A lot of times they didn't know it's prostate cancer, but that was the way for them to get the appropriate treatment. So the numbers are very high there. It's just we are not equipped to take care of it.
Thank you.
Good evening, Dr. Aldane. Thank you for your presentation. I had missed the first initial presentation, first part. However, I know that you're a medical doctor on a whole, but do you actually look at the holistic medical the holistic aspect of like
Medical care?
yes.
Yes, but it depends on what that looks like. So for one, at Loma Linda, we were taught to look at the person as a whole. So it's more of whole person care. We realized that there are aspects outside of the disease itself that can affect how someone responds to treatment or how the disease itself progresses. So I do try to do that as a part of my practice. The second thing is that where I practice, we also as a whole focus on that. And so holistic care looks different in different settings. For us, that's focusing on the mental health of a person, because if you're not mentally prepared to deal with the disease that you have, then we find that those people do not do well, even if the biology of the cancer was susceptible to the treatment that we're giving them. And then we look at certain times the patient might come in and say there is this over-the-counter supplement or some bush that their grandma gave them that they heard helps. For us with Memorial Sloan, we actually have a website of these herbs that we're able to double check and cross-reference if the patient can confirm. Things that we're looking for, we might not be able to prove that is truly helping. And some of them do, but we also look for potential side effects or interactions with what we're giving. Because we want to make sure that if you're taking something, it's not causing more harm than good. So we do look at that. If it's something that's not causing any harm, then I'm not opposed to you trying it, because if it works, that's great, as long as it's not causing any issues. So a lot of my patients, they talk about soursop and the soursop leaf. I'm not opposed to that unless there's an interaction with the medications. Now, can I prove that the soursop by itself works? No, but it is an anti-inflammatory that has been proven, and cancer is what we call inflammatory disease, meaning that it's hot or we have to cool down whatever is going around with it. So the soursop does do that, but by itself, does it cure you? Perhaps not. It might for a few people, but I can't say that is the case for everyone. I wouldn't recommend someone go out there and say, I'm going to ignore my doctor and treat myself with these bushes, because I do see what happens with that. I've seen a few breast cancer patients who decide to treat themselves. They were diagnosed at an early stage that we could have cured them, and then they come in with a breast that is falling off.
So just to, would you agree that exercise and diet is
One of the most important things, yes, to preventing cancer.
Thank you so much.
Doc, we have so many persons, but I'm only going to take 5 more. Okay? We'll take 3 more. Okay, so Brother Dallas.
Good evening, Doc. Wonderful seminar. And I must say some of the questions that we want to ask, or we should ask, we may telling ourselves that we already know the answer, but a lot of people in here may not know. So even though you may know the answer, still ask, because somebody around may not know. But 2 questions I would love to ask. Your prostate, is it naturally getting large as you grow? That's the first one. Second question, what can you do to, or what medication can you get to reduce the growth, if it does?
So it has a set normal range. It shouldn't keep growing after you're an adult. So if it's growing, something's wrong. To the second point, it depends on what is causing your increased prostate. So if it's what we call benign prostatic hyperplasia or BPH, then we have medications that we give for that and it shrinks the size. If it's cancer, then you need treatment for the cancer. Those are the two things that can cause it. There's also potential infection of the prostate, then we treat that with antibiotics. But there's no preventative medication or supplement to prevent you from developing either of those.
Thank you. Thank you.
Hi, doctor. I just have two questions, both related to food, whether or not if it's a myth or a fact. I remember a study done where they say that eating too many barbecued charred pieces increases the risk of colon cancer.
That is a fact because the charring is what we call a carcinogen, meaning it prompts the cells to become mutated and develop into cancer. So that is a fact. So when you barbecue, you try not to get that charring because it does increase your risk of cancer.
And also the same thing in terms of black pepper. Does using too much black pepper also contributes to colon cancer?
That one, I don't have the data on, but I could see how it would based on it altering what's going on. And processed seasonings in general can have that effect if you consume too much. And so that's why the recommendation is to blend your spices when you're seasoning your chicken and so forth, because it is missing all the processing from the things we buy. But the data I don't have.
Thanks.
Mm-hmm.
Good evening, Doc. I'm not sure if this was dealt with because I was outside, but in my mid to late 20s, I was doing a little research on prostate cancer, and I read this article which states that animal fat is one of the main contributors to prostate cancer. Is there any truth in that?
It's a main contributor to cancer in general. So we do advise that if you're eating meat, then you try not to eat the fat and the skin for that reason.
Thank you.
It also contributes to heart disease, diabetes, all the things we don't want.
This is very informative. I will say a lot of people are learning. I myself am learning. There's a statement that I would like to make. It was mentioned earlier. The gentleman brought up tofu, soybean products, as it being harmful. So, and you had made mention that the data is conflicting. And so what I have discovered, because I've studied health, I'm a certified health coach, what I have discovered and seen the data on that is that soy in general receive a bad rep because of the fact that the protein in soy is very high. And so what tend to happen is just once something is good, then overproduction of it, and then they started using a lot of pesticide in producing it to make it bulk, and then now you have it being contaminated. So if you're going with organic soy, then it still has the 9 essential amino acid. It's very beneficial. The idea about it being estrogen dominant and harmful and can cause cancer has been unfounded. It's just because of the pesticide used to produce it. So again, if you're using organic tofu, and again, we want to do everything in moderation. You know, back in the days, coconut oil also was given a bad rep for being cholesterol-based, saturated fat, and we find that coconut oil is very good. But that being said, I did want to ask a question based on, in terms of treatment, when individuals are, that you see in your practice that are dealing with colon cancer and, colorectal cancer, are they, advised or encouraged to follow a whole food diet, or are they told that they can eat hamburgers and French fries and milkshake?
So it depends on the stage of their treatment. So if someone is starting intensive treatment and they just had significant weight loss, then the recommendation is to eat whatever you are able to eat. As you start to stabilize, at least in my practice, we have them meet with nutritionists, and that helps them to balance out what they're eating. We do try to encourage eating mostly healthy foods, but earlier on in the treatment course, we don't limit our patients because we find that that limitation is more harmful in the long run than letting them eat whatever they're willing to eat at that point. And that's because to tolerate that treatment, you need as much nutrients, but because of the cancer being advanced, especially in advanced stages, your body, one, does not get enough nutrients from eating basic things, and then you don't have an appetite. So it's not a hard answer. It's more of where is that person in their treatment protocol. And we don't encourage them to eat hamburgers. If they say that's what they're eating, we don't stop them. Let me clear that up. Ah. All right. All right. Thank you, everyone.
Thank you, Doc. Wow. Hello.
Okay, put your hands together. You wanted to do so. That is still fenke fenke. Or you don't know that word? Okay. Thank you. Thank you very much. Thank you very much. Let's just settle down very quickly. Knowledge is power. We have received much information. I was around the back. I was hearing a little bit of what was happening. And I think that none of us could pay for all the information we got this evening. We did not only get information through a presentation, but you were able to ask your questions. They were answered respectfully, truthfully, and in the spirit of Christ. That makes the presentation different from one you would have had anywhere else. And so on your behalf, let me thank Dr. Hoylett for taking time out. Well, it's Sabbath, but he could have been elsewhere. For taking the time to come to us at Philadelphia, his church, after all. Right, Sister Cindy? Sister Cindy says he belongs here. You second the motion? Okay. Your baby? Ask him. I thought it was Sister Cindy's baby. Yeah. Anyhow, Sister Mary is claiming the doctor. That's all right. It belongs to all of us, and we are happy to have him. This is just number one. There are other sessions that we will have with him. We're going to have him for maybe health fair. I think I'm hearing something like that. And we just want to let him know that Philadelphia is proud of his achievements. Amen, amen, amen. And also, we are going to keep him sustained with our prayers. For we know that this is first world country, and medical liability is expensive for them as doctors. But with Christ as his guide, no such evil will befall him, and no such plague will come near his dwelling. What do you say? So, Doc, on behalf of all of us, thank you very much. And I'm sure if any man wants to have a little private consultation, he won't charge you for it. Or I know there are some little delicate things where men are concerned that we are very particular about. I heard Brother Frey try to get there. And if you need that little assurance, then just have a word with him as he is available. Thank you very much. We have come to the end of a perfect day. What do you do when you come to the end of a perfect day? You thank God for what he has done for you. There's a song that says, Sister Augustine, day is dying in the west. Even if we can sing one stanza, stand with me because we have the 8 o'clock session with the prayer ministry from the conference. So we're going to join on. That's it. 51. 51. Come, let's sing this song. Come on. Day is dying in the west. Heaven is touching earth. Wait and worship. Sets her evening lamps, the Lord through all. Holy, 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 Lord God of hosts, God of hosts. Heaven and earth are full of thee. Heaven and earth are praising thee, O Lord, most. Lord of life beneath the dome, Lord of life beneath of the universe, Gather us, O seek to the fold of thy embrace, for thou art nigh. Holy, 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 Lord God of hosts. Heaven and earth are full of thee. Heaven and earth are praising thee, O Lord, most. While the evening shadows fall, while the evening shadows, heart of love enfolding through the glory and the grace, of the stars that veil thy face, our hearts ascend. Holy, 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 Lord God of hosts. Heaven and earth are full of thee. Heaven and earth are praising thee, O Lord, most. When forever from our side, when forever from us, past the stars, that day, Lord of angels, honor, let eternal morning rise, and shadows and holy, 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 Lord God of hosts. Heaven and earth are full. Oh, heaven and earth are praising thee, Brother Thomas, could you come and dismiss us with prayer?
Before we pray, I would just like to thank everyone who stayed back to be a part of this program. It was nice to see so many of us. It was a wonderful presentation. We learned a lot, and we hope as we leave to share the information that we learned with someone who was not here this evening.
Let us pray. Heavenly Father, we are so thankful to you that you have blessed us. You have brought us through another Sabbath day, and now that we have come to the end, we ask that the blessings that we stood in need of, that we have received. We pray, O Lord, that you will be with us as we go through this new and untried week that is ahead of us. We ask that you will guide, guard, and protect us. We thank you for also sending your manservant to share with us issues relating to the health and welfare of our bodies. Help us, O Lord, that they will not be just words that we hear, but if they affect us, help us that we will take heed and we will seek help when we can. We thank you now, Lord, and we ask that you will dismiss us with your blessings. And as we leave from these courts, grant that we will not leave from your presence, but we will always remember, we may always trust you, and may we do everything, O God, that you have taught us, so that we can live healthy and more fulsome lives. We ask also, dear Lord, that you will lead us as we enter into the next aspect of this evening's program, as we tabernacle with you and we agonize and we pray. Be with us, we pray, for Christ's sake.
Amen. Amen.
Thank you, Elder. Sit down for a moment now and let us not rush. Say, if I have wounded any souls today, if I have caused one's foot to go astray, if I have walked in my own willful way, dear Lord, forgive. May I wish for you a good week, peaceful week, a profitable week. And I remind you that the Lord's special service is at your command. For he says, he that dwelleth in the secret place of the Most High shall abide under the shadow of the Almighty. With God by your side and you holding on to faith, there's nothing that you and your God cannot accomplish this week. So, go in faith, go with confidence that Daniel's God surely will deliver. Have yourself a good week. Sister Berry wants you to be online at 8 o'clock. And we are doing the first session. So we're going to support Elder Berry online and the prayer ministry team. So we ask that you get home as quickly as you can. I gave you the Zoom link this morning. Have mercy. You didn't get it. Anybody has it? I have it in the back. Did anybody write it who can share it? That Zoom link, okay, it's coming up, is it? Okay, there it is. The Zoom link is 276 595 8062. Thank you, Elder Nemhard.
Let's play something.